Dear colleagues, it's an honor to be here, and let me present you my PhD topic, Prognostic Factors of Serum Biomarkers in Urothelial Cancers. My name is Ádám Széles. I'm a part-time resident and a PhD student here in the Department of Urology in Semmelweis Clinic. My vision is therapy optimization in immune checkpoint inhibitor usage, and as a mission, I would like to assess the utilization of biomarkers in urological cancers treated with immune checkpoint inhibitors. These are my 3 ongoing studies where I will assess different biomarkers in aspect of immune checkpoint inhibitor usage. So let me go one by one. The first one, title is Investigating the Prognostic Significance of Soluble PD-L1 and Soluble PD-1 in Human Malignancies Treated with Immune Checkpoint Inhibitors. This will be a systematic review and a meta-analysis. So, I think it's out of any question that cancer is one of the most important life burden in today's life, and immune checkpoint inhibitors are prosperous drug to treat cancers. As you can see in this picture of a drawing of 2 gentlemen who earned the Nobel Prize in 2018 for the discovery of immune checkpoint inhibitors. So how immune checkpoint inhibitors work? As you can see in this picture, the tumor cells and the T cells, they both expressing PD-L1 and PD-1, and if these receptors bind together, that causes an immune suppression. So if you block it with an agent, that can cause an immune boost, so the T cells will more likely kill cancer cells. This sounds really promising, but what we can see in the practice is that immune checkpoint inhibitors are really effective, but for a small amount of patients. And in this study, we would like to assess the soluble version of these receptors. Here's a previous meta-analysis that's been done in this project. This name is the prognostic value of circulating serum PD-L1 in cancers. So they focused on all kinds of cancers, and you can see they had a positive result that serum PD-L1 is prognostic. And what we want to do differently is want to assess with all kind of the serum PD-L1 with all kinds of cancers, but we have a restriction to therapy for immune checkpoint inhibitors, so to leap a step forward from prognosis to therapy prediction. If we make a clinical question that does serum PD-L1 and serum PD-1 have a clear, well-defined prognostic value in human malignancies treated with immune checkpoint inhibitors, and if we construct a PICO framework that will look like this. Population is all kind of cancer, and we are comparing a high-level concentration and the low-level concentration of these biomarkers based on a predefined cutoff value, and we choose outcomes like overall survival and progression-free survival. The clinical implication is biomarker-based decision in clinical practice. We did the systematic search in the following 4 databases with the following search key, and we found 458 articles, and when we did the selection process, now we have around 30 potentially eligible studies, and we are in the phase of data extraction. My next project is a really similar prognostic meta-analysis, but this time I will investigate the prognostic significance of neutrophil to lymphocyte ratio, platelet to lymphocyte ratio, CRP, and LDH, but this time in urothelial cancers, but again treated with immune checkpoint inhibitors. About the background, bladder cancer is among the top 10 most prevalent cancer in the world. And unfortunately, metastatic bladder cancer's 5-year survival is only 5%. So, and at the time when it is metastatized, we had to give some kind of systemic agent. We either have platinum-based chemotherapy, and we also have immune checkpoint inhibitors. And the aim of this study to highlight the importance of laboratory markers in clinical decision-making. The clinical question, I think it's really similar to the previous one. Does these biomarkers have a well-defined prognostic value in urothelial cancers treated with immune checkpoint inhibitors, with again a similar PICO? And the clinical implication of this study is to use laboratory parameters to support clinical decision making. We did the Prospero registration, and now from the next week we will start the systematic search. My third project is the prognostic significance of soluble PD-L1 in upper tract urothelial carcinoma. This will be a retrospective cohort analysis. So, Upper tract urothelial carcinoma, or shortly UTUC, is a rare disease. It only takes 5 to 10% of all urothelial cancers. And you can see we have a standard therapy options like surgery, the radical nephrectomy ureterectomy, and because it's a urothelial cancer, we again have platinum-based chemotherapy and immune checkpoint inhibitors. And I would say that the clinical management of these kind of cancers is a bit more complicating, because you can see on this slide that the UTUC in an early stage can block the flow of the urine, and it can cause to a kidney damage. And platinum, cisplatin, is the most effective kind of platinum in this kind of cancers, is kidney toxic. So you can imagine if you want to give a kidney toxic agent to a previously lowered kidney function, is not the best solution. So I would highlight this, that immune checkpoint inhibitors, potentially eligible patients, is even more important in this kind of cancers. This is our cohort. We have around 65 patients, which sounds small from statistical view, but this is a rare disease. So from the biological perspective, I think it's quite normal. We have a pre-treatment and post or on-treatment samples as well. We have 3 different groups that based on the management. We have the surgery group, the chemotherapy group, and the immune checkpoint inhibitors group. We did the analysis with sandwich ELISA, and I can show you some preliminary results. We made a cutoff value based on the median of the serum PD-L1 in both in the surgery group and in the chemotherapy group. And you can see in the overall survival, we have statistically significant difference within these groups. And we are still collecting data from the immune checkpoint inhibitors group as well. Another important comparisons will be in this study is the age, the sex, the ECOG status, staging, grading, kidney function, metastases. And because I mentioned we have post or on treatment as well, we would like to see the follow-up of these biomarkers. Just a quick overview of my 3 ongoing studies. And I would like to thank you for your attention with the words of Walter that I disapprove of what you say, but I will defend to the death your right to say it. Thank you very much.
In your second study, if we can go to the PICO, are there clear cutoff for high level and low level?
Of these biomarkers?
Of the markers.
For neutrophil to lymphocyte ratio and platelet to lymphocyte ratio, there is. For CRP level, well, most of them it has, but again, it's different because of the countries. But this focus on one kind of cancer, so yes, mostly I say we have a clear cutoff value. Not for the PD-L1, the serum PD-L1, because that's a novel biomarker, and in this, most of the studies, they are different.
Yeah, well, the other thing, I mean, now you have 4 markers which should be high, and then 4 should be low. I mean, CRP is increased in many cases when not the other ones. So how do you deal with this? So this is going to be a composite kind of stuff, or what do, this is a meta-analysis. So how do this handled by others?
I don't know if I understand clearly your question, but why these are important for us?
No. In your eye, there are high levels for 4 biomarkers.
Yes.
And in C, there are 4 biomarkers which should be low.
Yes.
But there are going to be patients who are high for CRP and low for LDH.
Yes. Then we'll make subgroups. Clearly, we will make subgroups based on the different biomarkers. So we will concentrate, and we will see from the results if we can make some comparisons within these subgroups of different biomarkers.
And I also assume, I mean, I'm just trying to see if there are going to be some difficulties. So are all studies standardly measure all these 4 biomarkers?
Well, not really, unfortunately. Most of the studies are the heterogeneity. There will be a problem in this meta-analysis, of course.
Okay. Beautiful progress, beautiful presentation, lots of good things. Attention to the detail is, you know, I'm a perfectionist and you are a perfectionist. So if the outcome is mortality, you should be measuring mortality. What you are measuring is survival.
Yes. Overall survival, progression-free survival.
Yeah, and that's not mortality. That's the reciprocal of mortality. I would just suggest that you are measuring survival and not mortality.
I see, yeah.
Because OS and PFS is measure of survival and not
yes.
measure of mortality.
You're right, thank you.